Hi,
Hello,
everyone.
everyone, and welcome to our webinar, Serious Illness Conversations, Your Approach Matters. My name is Lauren King, and I am the Community Education and Caregiver Academy Manager at Coastal Hospice. Welcome to our Caregiver Academy. Among our attendees today, we are happy to see so many familiar organizations with us. We have colleagues from Tidal Health, Encompass Rehab, Highmark Blue Cross Blue Shield, Shore Regional Cancer Center, the VA, and many more. It's wonderful to see everyone today. Before we begin, allow me to go over a few housekeeping items. You may see myself or my colleagues, Alejandra and Joy, pop up in the chat box to help or address with any technical issues. I want to thank you for your patience ahead of time, should we have any. I'll also come back at the end to discuss the program evaluation. We will be using the chat feature to communicate with you throughout the webinar. You can access it by clicking on the messaging icon in your meeting control. Our webinar today will be moderated by Lauren Blair, Community Relations and Development Manager and Caregiver Academy Moderator at Coastal Hospice. Lauren has more than 15 years of experience in the healthcare field. She holds a master's degree in social work from Salisbury University, is a licensed master social worker in the state of Maryland, a licensed clinical social worker in the state of Delaware. Lauren also serves on the board of directors of the Grace Center of Maternal and Women's Health and is a subject matter expert for the Dementia Care Resource Initiative through the National Partnership for Healthcare and Hospice Innovation, and a nominee of the 2023 Women to Watch of the Chesapeake. Lauren, I'll hand it off to you.
Thank you so much for that introduction, Lauren. We're happy to see so many of you in attendance today. Thank you for dropping in the chat, and please continue to do so. It's my pleasure to welcome and introduce Dr. Joan Carpenter to you all today. Before I do that, I'll share with you the disclosures for continuing education for those of you who are getting continuing education credits. For physicians, this activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accredited Council for Continuing Medication Education through the joint providership of Tidal Health Peninsula Regional and Coastal Hospice. Tidal Health Peninsula Regional is accredited by MedChi, the Maryland State Medical Society, to provide continuing medical education for physicians. The Continuing Medical Education Committee of Tidal Health Peninsula Regional designates this activity for a maximum of 1 AMA PRA Category 1 credit. Physicians should only claim the credit that commensurates with the extent of their participation in the activity. The planners, speakers, and Continuing Medical Education Committee of this educational activity declare that they have no relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. For our nurses, the Tidal Health is an approved provider of nursing continuing professional development by the Maryland Nurses Association and accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. In order to receive contact hours provided by Tidal Health, you will need to attend the entire course, missing no more than 10 minutes, and complete the following course evaluation with post-test. The speaker presenting today does not have any financial disclosures to report. And for social workers, Tidal Health Peninsula Regional is authorized by the Board of Social Work Examiners in Maryland to sponsor social work continuing education learning activities and maintains full responsibility for this program. This training qualifies for Category 1 Continuing Education Unit. We are very excited to have Dr. Joan Carpenter here with us today. Dr. Carpenter is an expert in geriatric palliative care, specializing in caring for older adults and their families. She is an assistant professor at the University of Maryland School of Nursing, a health scientist at the U.S. Department of Veterans Affairs, and a nurse practitioner with Coastal Hospice. Her practice and research focuses on palliative care interventions to improve the quality of life, reduce symptom burden, and enhance decision-making for persons with serious illness and their care partners. Thank you for being here with us today, Dr. Carpenter.
Thanks so much, Lauren. It is a pleasure to be here with everyone today. And I saw that we have folks attending from home healthcare agencies, hospice agencies, nursing homes, long-term care. So it's, and you know, those in the community. So it's really fantastic to see how many people have joined us, and we're now up to 63. And obviously this is a topic that's of great interest to clinicians in all settings of healthcare. And in a way, I guess I can't say I'm too surprised, because I think this is, Lauren, as we've talked about before, this is a topic that lots of people want to learn more about because of what we do working with people with serious illness. I do want to take a moment to acknowledge the U.S. Department of Veterans Affairs. This training or this presentation today was adapted from materials through the VA. And this is a national quality improvement project that's been done through the Veterans Affairs healthcare system that I've been closely involved with since 2016. And their goal is to improve personalized, proactive, patient-driven care for people with serious illness by eliciting, documenting, and honoring their values, goals, and preferences. And as I mentioned, this is a national quality improvement project that was launched in 2017 called the Life Sustaining Treatment Decisions Initiative. These materials that I'm going to be talking about today and referring are freely available on the VA website, and it is noted here, and we will be sending these slides out in a PDF form for you to access. And we also have some additional links in the slides that you can use to access more information and resources to help you in having conversations. Okay, next slide, thanks. So when we're finished today, we want you to be able to do several things. One, to be able to explain the importance of ongoing communication about care goals with seriously ill individuals, and also to be able to describe the central factors in communicating serious illness news, as well as conduct a goals of care conversation using some key communication skills we'll be reviewing today. And, all in all, what we'd like for you to be able to do is to be able to carry out a plan to conduct goals of care conversations with seriously ill patients in your individual clinical setting. So keep in mind, goals of care conversations take practice. In the VA, this particular training is accompanied by role-playing and practicing some of the communication skills that we talk about today. And that's a very deliberate way of delivering the training. We're going to be using the didactic portion today. And remember, you're not expected to be an expert once you've viewed this program, but today you'll get some tools to be able to build your skills over time. And we have some other folks joining us from Tidal Health Primary Care. Great.
Yeah.
Okay.
So what is the goals of care conversation? What does that look like?
So goals of care conversations are communication that occurs between patients, their healthcare team, and ideally their trusted family members, friends, and support system. Goals of care conversations include the patient and what's important to them, information about what they value, what they want their healthcare to achieve, and what they prefer. So treatment preferences. So based on that information, shared decisions can be made with a patient about the services and medical care that's going to best meet their needs.
The shift in culture. Yes, I want to hear more about this. What does that mean?
Yeah, so Lauren, imagine you're seriously ill and you're in the hospital and you're asked this question. Do you want us to do everything for you today? What would you say?
Yes, of course. I want everything done that can be done for me.
So too often patients end up in a health crisis in the ICU, in different care settings where they may be too sick to make their own decisions. And it's not just the ICU. These are people, people may not be able to make their own decisions who are in a long-term care setting, maybe in their home setting. And so they're in a healthcare crisis, and it's before anyone has asked them about their goals of care and about their preferences for life-sustaining treatments. And what this slide is really demonstrating is that we are shifting our culture to begin the conversation about goals of care earlier in the course of illness. So we want to begin communicating before a crisis. We want to communicate before there's a loss of decision-making capacity. Well, the patient and their family have time to consider what's important to them and then discuss it amongst themselves. So instead of asking about treatment decisions without knowing much about the patient, we want to shift our culture and conversation to first find out about the patient and what they care about, their hopes and their goals, what they want to avoid, maybe, and then work with them to design a treatment plan on that basis. So you see our previous approach, and I think everybody here today, all 67 participants now, can think about, how healthcare conversations about healthcare have changed over the past probably 10 to 15 years. You know, the previous approach, and sometimes it still does happen, obviously, during a healthcare crisis. And we say, do you want us to do everything to you? And we're really shifting that to having the conversations earlier and asking people, what do you hope to achieve with your medical care?
That makes sense. I see Terry says, bravo. It's so true. We need to have these conversations before we think we need to, for sure. So Dr. Carpenter, how does knowing your patient's goals help with decisions about treatments?
Yeah, and on the slide, we include patients and residents because we think about, you know, there's patients in the hospital, there's patients in the community, there's residents in long-term care facilities and long-term care settings. So we want to think about, you know, all of the different people we may see with serious illness and how knowing their preferences depending on, or their goals and their preferences depending on where they live, based on the stage of their illness, how that helps with decisions about treatments. So think about times when you may have a patient who returns to the hospital multiple times and says, you know, I really don't want to be returning to the hospital. And you know this, right? You know, you hear them say this, but then nobody ever really approaches that conversation and says, tell me about why you don't want to be in the hospital, but tell me why you come here. Or, you know, you may have a family who wants to pursue a certain line of treatment that, you know, the patient really is not in favor of. And oftentimes it's when the conversation hasn't occurred in a setting that's involved all of those people, that then treatments may be pursued that aren't really in alignment with what a patient wants. So knowing what their goals are can help to align their treatments with their preferences.
Making sure we're actually doing what they want us to do.
Exactly. Exactly.
I'd love to get the audience's perspective on this next one. When should we discuss goals of care? Drop your thoughts in the chat box. Let me know what you think. When do you feel like we should be discussing these things? I know when I think about, oh, can't be too soon, Terry. Yes. Yes. I know when I think about this, one of the things that comes to mind is the lack of time. I know practitioners may not always feel like they have enough time with their patients to fully discuss goals of care as they would like to. Let's see. I have Heather. Heather says at the beginning. Let's see. Yeah, Terry says can't be too soon. Gigi says that everyone's annual wellness visits. We got on admissions at the beginning. Love the suggestion for annual for all of us. Yes, exactly. As early as possible, as many persons have not thought about this in depth from the very beginning. These are great. This is great.
Yeah, this is great, Lauren, and thanks everyone for being so involved. It's a much more fun webinar when we get to talk about some of your feedback and some of the answers to the questions. So it sounds like maybe our work is done here, Lauren, because everyone knows to start talking about the goals of care at the beginning, after a hospital visit, all the time, as situations change, as early as possible, although it may not be as in depth, and that's so true. So, you know, and what we think about, you know, if there's one way to kind of apply this universally, when a patient or, you know, a person that you're working with serious illness is at risk of a life-threatening clinical event in the next couple of years, it's across the board the time to be having these conversations in any clinical setting before the health crisis is best. And remember, it may take more than one conversation, and it may involve more than one clinician. So as you all have been saying, as early as possible, having these conversations as early as possible after a hospital visit, as situations change, that's exactly right. Because the conversations occur over time. Oftentimes, it is many conversations. It's not one and done, which kind of is a prevailing culture a little bit now. Also think about if someone brings up the conversation to you, even if they're not, you know, necessarily at risk of a life threatening event, but if a patient brings up the conversation, it's a good time to have it. And as we mentioned, ongoing conversations throughout the disease process. I know, can we do commercials on TV to educate our community? I will tell you, there is a great it's almost like an initiative around palliative care for consumers. And I can certainly provide a web link for that after this webinar about how to, you know, different messaging about palliative care and about having conversations about serious illness. So I can provide that.
Great. Great. Thank you, everyone. Let's get the audience involved again in this next one too. Who is responsible for goals of care conversations? So how about who? Who do you feel like should be the ones having the conversations? Let me know in the chat. Everyone, we all are. Everyone on the team, all parties, everyone, care team, providers, everyone. Yes, great answers. I hear, when I go out to the community and talk, I hear a lot of specialists kind of don't want to step on the primary care physician's toes, so they're not having the conversations. But then same with specialists, they're not necessary, or same with primary care, they're not wanting to step on the specialist's toes, so then they're not having the conversations. But really, we can all discuss it. We can all be a part of that.
Absolutely. And this is, like I said, our work is getting a little easier because it sounds like a lot of the
I
audience,
know.
understands. They
Yeah.
understand that we're all responsible. But we have varying levels of expertise about what we can discuss and what we feel comfortable discussing. And I'm just going to review a few things right now. All of us, all clinicians can introduce a goals of care conversation to the patient or family. Just introducing it, just saying, hey, just want to talk to you a little bit about, what's important to you. What are you thinking about how things are going? Discussing the role of a surrogate and identifying a surrogate. We can all do that by asking a patient or, who would you want to make decisions for you if you're unable to make your own decisions for your health care? Trying to find out what a patient understands about a diagnosis and a prognosis. We can ask that, tell me what, and we're going to talk about these communication skills and how to do it. But, what do you understand about your illness? How do you think things are going? One topic I would reserve for providers who are prescribing treatments, diagnosing, are delivering news about a diagnosis or a prognosis. Oftentimes we should reserve that for the clinician who is overseeing the care for the patient to deliver that serious, especially when it's serious illness news. But all of us can elicit a patient's values and goals, ask them what's important to them. We can all provide basic information about life-sustaining treatments and services. We can talk about what a life-sustaining treatment is, such as use of CPR, such as use of, medically administered nutrition, things like that. We can also document a conversation. All of us as clinicians can document a conversation if someone has expressed to us, what they understand about their illness, or maybe who they want to be a decision maker, or what kind of treatments they may be thinking about and they may want.
Absolutely. Yeah, Gigi brought up a good point. Primary care physicians have special relationships and should offer conversations, but also specialists, really should make sure that their patients are informed about the states of their disease process. So very good point. Again, that's why we can all be a part of it. And I think Heather brought up a great point too. Medical professionals also need to encourage patients and their families to talk to each other and to let each other know what they want and don't want. And so that if the family needs to make a decision at some point, they know what the patient would want. That's a great point. Let's get one more that I want to grab the audience for. What is hard about having these goals of care conversations? Again, just type it in the chat. Let me know what you feel like is hard about having these conversations. I think there's a lot of hard things to have about the conversation. For me, it's all the emotions that are involved, the fear, the sadness, the anxiety. All those things can be really hard for patients and for healthcare providers in those situations to chat about.
Mm-hmm. Yeah, I mean, talking about death can be hard, and we're not all taught how to do this in our formal training programs. It's difficult making sure everyone's on the same page and has common goals. Exactly. Time. This is that is so important. It takes a lot of time, and you can't rush these conversations. So often as a palliative care provider, it's you get this consult. Can you help get us to a DNR? And it's like that's not the purpose of these conversations. These conversations are to talk about goals and preferences and align the treatments with those goals and preferences. Some other people saying, families aren't ready. That's very true. People often think this is it. They're going to die. Yes. If you start the conversation, they think you're giving up hope and that this must be a terrible sign if we're having a conversation about what's important to me and life-sustaining treatments. It's the prevailing culture in our society too. The goals may not be what we want and we don't know how to proceed. That's so true. Or they might align with us, and I think we do have biases sometimes around what we think people should do and what we think maybe they will do. And when it may not be what we would choose for ourselves, that can make us a little uncomfortable. You don't know where the patient is emotionally and psychologically. It's so good. And we're going to talk a little bit about emotion today and how to handle emotion, having these conversations. So hopefully you'll feel more comfortable.
Yes, all great ideas. That we got a lot of great conversations for future conversations, Dr. Carpenter, I think.
Yeah.
Thank you so much, everyone, for participating. So moving on to tell us about why our approach matters.
Yeah, so the attitude that you bring as a clinician to a goals of care conversation is pivotal. You want to create a safe and open environment that fosters a true partnership with the patient and their family. You want to check to make sure that a conversation is moving at a pace that's comfortable for the patient. You want to instill the belief that a patient can make a difficult decision. We don't have to make decisions. We have to tell people what to do. Patients and families can make decisions. And you allow, in this approach, you allow a patient to discover their own understanding through their experiences, their thoughts, and the emotions. At the end, your attitude is foundational. And the communication skills and tools that we're going to talk about today are part of that foundation.
Great. Tell us about why the words we use matter so much.
Yeah, I mean, think about all of you can read these phrases and you think, what's the first thing that comes to mind? Lenore and I already talked about the do everything one. Comfort care only. Does that mean we're not providing any other care? What if the patient still wants to receive nutrition through a feeding tube? We have no more options. There's always options. There's always options to care for a person living with serious illness or life-threatening illness. It's time to withdraw care. That may signal to a patient or a family we're no longer providing care, like essential care, right? So that's a tough one. And then restart. I think restart, I always associate this with like starting the car or pushing a restart button. And that's not what we do in healthcare. We provide treatments that are focused on a goal or preference for the patient and the family.
These are all phrases that I'm seeing on here that elicit a lot of emotion. Dr. Carpenter, tell us about our next slide, expect emotion.
Yeah, emotion occurs frequently in goals of care conversations. They address difficult topics, loss, illness, care at the end of life. And, as we talked about on a couple slides ago about how these conversations can be hard, it's not unusual for a patient to experience emotion during the discussion. And as a clinician, it's not unusual for me to often feel emotion too, because these are in-depth and very personal conversations. It's important to remember, though, that emotion impacts a person's ability to process information. Emotion can increase stress and anxiety, and it can trigger that fight or flight mechanism that we all have. And during times of high stress and anxiety, the frontal cortex of the brain doesn't process information as effectively, and it can impair our ability to make decisions. So remember, high emotion can impair our communication processes and reasoning and decision making. So we want to expect emotion during these conversations. It's not uncommon.
You talked about how much our brains can process at one time. Do you feel that sometimes it takes more than one conversation with the patient and their loved ones?
Absolutely. Absolutely. And you may find sometimes that you think, I thought we talked about this last time we had this conversation. I thought this was the same exact conversation we had. And you may realize that a patient and their family may not have processed the information because of that feeling of stress and anxiety. And so by creating a partnership and creating an environment that's safe and comfortable, you can help to reduce some of that anxiety.
Sure. So Dr. Carpenter, we know that we can expect emotion from those that we're having difficult conversations with. What are some ways that we can recognize these emotions that go along with it?
Yeah, emotional responses are not the same for everyone. And sometimes when experiencing high emotion, patients may ask a question, and we'll talk about how to answer questions in a little bit. But, you know, what do you want to do, Lauren, whenever a patient asks you a question? What's the initial thing you want to do?
I think I naturally just want to give them the answer to their question to the
I
best of
know.
my ability.
Yeah, and so providing an answer is usually what may not be needed during this, and when emotion is high, right? So
Mhm.
asking a question, it may not be the thing to do. What what a skilled clinician and what you want to think about doing is recognizing the emotion that's behind the question and respond with empathy to the emotion rather than responding with facts in a question. So if a patient says, "How did I get this cancer?" It's much better to say, "This must be really stressful for you," instead of explaining the pathophysiology of cancer and metastasis. So when a patient is experiencing emotion, it's hard not to answer a question with facts. This is difficult, but an important skill. So some cues that people are experiencing emotion is maybe shutting down and being quiet. Maybe their body language is showing that they're not as interactive with you. However, on the other hand, a person may become a little bit more active. They may be using their hands, they might be fidgeting, they might be moving around a lot. Their voice may change, the intonation may change. They might be high pitch, there might be a low pitch. And you might just start to notice some ambivalence and resistance. And we're going to talk about that on the next slide. So ambivalence is having two or more desires that conflict. And as you see here, this is, also something I said earlier. When a patient says, "I don't like coming to the hospital, but it makes my breathing easier," you know, obviously they're having some conflict there. They have two or more desires that conflict. Coming to the appointments is difficult. I don't like the idea of coming to my house. I'm sure there's a lot of folks out there that are in home care who have heard this from patients. Um, but ambivalence, it can be apparent or it can show itself over the course of a conversation. And I'll tell you, often patients and families don't realize their desires conflict. And you can recognize this and help to walk a patient through it. We're also going to talk about resistance. And resistance occurs when we expect or we push a conversation when the patient isn't ready. And I think we probably all have witnessed this or have been a part of this. And it's not uncommon. I mean, we are not always as skilled with these conversations as we'd like to be, but I always believe we're always trying to get better at them. Resistance is normal. It can be obvious or it can be unknown. So here's a couple quotes that can show you resistance. "I wrote everything down 20 years ago in my advance directive," right? That's a good way to say, "I'm not going to talk about this right now. I don't see why I need to talk about this right now." Someone may even say that to you. And trying to move somebody forward in a conversation with something they're resisting may damage the rapport that you have with a patient and their family. But we'll talk about ways to work through resistance with a patient.
Great, wonderful. Yeah, so tell us about what communication skills that we can use to combat some of these.
So we're going to talk today about open-ended questions, reflective listening, exploring affirmations, and "I wish" statements. And using these communication skills is vital in conducting a goals of care conversation where you're likely to encounter emotion, ambivalence, and resistance. So we'll go ahead and start by talking about open-ended questions. Open-ended questions elicit a patient's own knowledge in their language, and reveals their understanding and or their feelings. Um, as we all know, closed-ended questions limit responses to a yes or no or a one-word answer. So when you look at these two questions in red today, think about if you ask somebody, "Does your health affect your day-to-day life?" All you're going to get is a yes or no, likely. But if you say, "How has your health affected your day-to-day life?" you can maybe gain a more accurate picture of what the patient knows and understands. Again, another question. You mentioned you have heart failure. What's your understanding of that disease? Much better than saying, "Do you understand what heart failure is?" That's a yes or a no. So you see the difference between a closed-ended question and an open-ended question and how it can really help you to gain a much more accurate picture and understanding of a patient.
Absolutely.
So we're going to move on to talk about simple reflections. Simple reflections is just really repeating or paraphrasing a patient's statement. It encourages them to continue talking, it confirms that you understand what they're saying, and then it can reinforce concepts or knowledge. And reflections can be simple or complex. We'll talk about complex reflections in the next slide, but I want to finish out talking about simple reflections because they show that a patient that you're listening to them and that you understand them. And it's, again, building rapport. It's helpful to use simple reflections in response to specific phrases the patient has said. You want to use these frequently during a goals of care conversation. So here's a great example. My breathing is bad. I can't walk as far as I used to, and I have to wear oxygen all the time. A simple reflection is saying, your breathing has really been giving you a hard time. That's just simple reflection receiving back to the patient what they've said to you.
Quick kind of little summary, sort
Yep.
of.
Yep. Little summary. Yeah. Whereas complex reflections that we'll talk about on the next slide really go beyond a simple reflection by understanding the meaning behind a patient's statements, right? So you're doing a little more interpretation here. This helps to validate feelings and maybe explore deeper meaning of what the patient is talking about. This focuses on, as I mentioned, underlying emotion, values, beliefs. These can be really important in helping a patient discover greater insight into their condition. A patient may not even be aware of the emotion or the feeling until it's acknowledged in a complex reflection. And this helps to interpret the meaning behind a statement. It's complex. It takes practice. It does take practice. So if a patient says, "I don't want to come to the hospital anymore, but it makes my breathing feel a lot better," a complex reflection is interpreting that and saying, it sounds to me like what I'm hearing is you sound a little bit conflicted. And I do like to kind of use the term as, what I heard you say, what I'm hearing is that you are feeling conflicted. So those are a couple, so simple reflections and complex reflections. Now we can move on to talk about affirmations. Affirmations recognize the strengths and they acknowledge positive behavior. They help to build rapport and a patient's confidence. They focus the attention on the patient's strength and the positive behavior, and they're very useful when a patient might be struggling in some way. So if a patient's having a difficult time with the conversation, just affirming the simple action of engaging in the conversation, of being at the appointment to engage in the conversation is important. So the other thing I like with affirmations is that, and this is common for me if I don't know a patient and family very well as a consultant, that affirmations help to build rapport and confidence needed to discuss the values and the goals. So by saying things, you've shown so much support for your dad. And I use affirmations a lot whenever I'm seeing caregivers who are taking care of a person with cognitive impairment at home 24 hours a day, because it can be a really difficult job. And as an unpaid caregiver. And I do say, you're doing such a great job taking care of your dad at home. Tell me how things are going, right? So that's a great way to build some rapport.
Absolutely. I was in a meeting with a patient's family this morning, and the caregiver, that's what she told me. She said that, the best thing that I've gotten out of working with Coastal Hospice is the affirmation that I'm doing a good job, because some days I don't feel like I am, but they remind me I got, my loved one up and bathed and taken the best care of that I could. So I think those things, I think that's a great point about even the caregivers need that affirmation.
Yeah, and that you're affirming that they can do this.
Yeah.
That you have confidence that they can have this conversation. That you believe that you can do this. Again, shared decision making together.
Absolutely. Absolutely. Well, these are great. Let's talk about exploring next.
Yeah, so exploring is it seeks more information, clarifies meaning, builds a deeper understanding. It takes additional time for sure, but can be really effective in building clarity and a better understanding, because the issues that are brought up in a goals of care conversation can be difficult for patients. These may be topics that a patient and family has not thought about or discussed before. And often a patient's first response to a question is a safe response. But if you ask some exploring questions, the responses become deeper and reflect values, or their perspective becomes clearer. So these are a few phrases to use in exploring. Tell me more. What else? What do you mean when you say life support? And you can substitute anything in the quotes there. What do you mean when you say, X, life support? Breathing tubes, being a vegetable, what you can clarify using exploring. phrases.
What's an example of exploring that you've used recently or used before?
Yeah, I mean, so I think about, like, I ask a patient, what's most important to you? And the first thing that they tell me is, I don't know, just getting up in the morning. And I say, well, what else? And they say, well, I enjoy my coffee in the morning. And I say, well, tell me more about that. Tell me more about enjoying your coffee.
Mhm.
And then they say, well, every week I meet the guys at the coffee shop down the street, and we've been doing it for years. And these are, we've been doing this for 20 years, and these are the people I've hung out with, in my retirement. I can't imagine not getting together with them every week. And look at that, all of a sudden now
Mhm.
at a deeper place than we were when we just asked, what's important to you? And they said, getting up in the morning. All of a sudden now we're
Got it.
further along and really understanding what is important in their daily activities.
And the emotional connection tied to that, he wants to continue with, having these conversations and having these relationships with, the other guys at the coffee shop. So it's a great way of looking at things and looking more into it. I'm really interested to hear your thoughts about these I wish statements. A phrase that I get a lot that I've heard is something like, I'm praying for a miracle, or God's going to bring me a miracle. And, when people say this, I don't want to dull their hope. I don't want to diminish anything. So what can we say to something like that that's helpful, but also kind and gentle?
Yeah. So, um, I wish statements help to recognize a patient's hope, and they by using them, you can align yourself with the patient and the family.
Mhm.
And some of these are, I wish we had more. These are just kind of generic. I wish we had more effective treatments, or I hope for a miracle too. Um, it's important though, when you do use I wish statements, that you don't follow it with but. So for example, I hope for a miracle too, but
Mhm.
unfortunately it isn't likely. So when you say I hope for a miracle too, but it isn't likely, using the word but that kind of negates everything that you just said
Yeah.
to them.
Yeah.
And and all of a sudden, they kind of it really, you're no longer aligned with the patient, because
Mhm.
you're trying to give facts and you're not responding to their emotion. Just pause after someone says, if they say, I wish we had more effect. I wish there was something else we could do. You can respond, I wish we had more effective treatments. There are some other I wish statements that I wanted to, talk about that you can use. Statements such as, I too hope that blank happens, whatever it is that a patient may be talking about. You could say, I wish things weren't so stressful for you right now. I wish the situation were different. And you can align yourself. I hope, like I said, I hope for a miracle too. And then you leave it at that with the
Mhm.
silence, right?
That's a great way to build rapport with our patients too, because we're getting on their level and letting them know that we care, while also helping them to make informed decisions.
Exactly.
I see a question from the chat box from Terry. Terry asks, how do you address when someone says, I'm not getting better?
Well, so actually, this is a great question for the audience. I do have an answer, but I'm curious if anyone. We just talked about several. We talked about several communication skills.
Mhm.
We talked about open-ended questions. We talked about simple reflections. We talked about complex reflections. We talked about affirmations, and we talked about I wish. Oh, exploring was when I was talking about
Mhm.
open.
Mhm.
So, like, what does anybody have? Does anyone in the audience have a way that they would say, what would you say to somebody? Or Lauren, what do you think about, like, when someone says to you, I'm not getting better?
And just from what I've learned today here on this webinar is, asking, what does getting better look like to you? Or, I wish that or something like, I wish there was more treatments to offer. I wish there was something else. Deanna says, tell me more about what getting better looks like. Same thing I did. Yes, exactly.
Yeah,
Exactly.
these are great. I mean, this is great. And if anyone else has these really kind of tough phrases that you've heard from people, I'd love for you to put them in the chat. But I do like the idea of saying, tell me what looks better. Tell
Mhm.
me what getting better looks like for
Yeah.
you. You can say, I hear it sounds like you might be frustrated. Tell me your understanding of your disease process. I mean, I love exploring statements, I think, are some of the most helpful ones because it really gets you to what is going on in someone's thoughts. And, it really gets you a little bit deeper.
Yeah, gets down to the heart of it.
Mm-hmm. Mm-hmm. Exactly. Let's see. Yeah, tell me. Okay, good. Great suggestions. Of course, Terry.
Thank you, Terry. The questions can signal emotion. Tell us about this, Dr. Carpenter.
Yeah, so patients may ask questions when they feel afraid, when they are alone, when they're frustrated. Questions like, isn't there something else they can do for the cancer? Or why is this happening to me? Also, some other questions think about like, do you know something I don't know? Right? Like a question that can be a really tough one. Are you telling me that my brother is dying? So questions again, are you giving up on me? Why are we talking about this? So all of these phrases, all of these questions can be a signal of emotion. And you want to watch for questions that are actually expressions of emotion. Again, they may show that someone's afraid, alone, angry, or frustrated. And as we talked about before, instead of responding to a question with facts, respond with empathy to the emotion behind the question by using some of the communication skills we just reviewed. So, do you know something I don't know? You could say, tell me more about what you're asking. Or you could say, you seem worried. That's a reflection, right? You could say, what's your understanding of things? You could also use, okay, so someone says to you, are you giving up on me? It sounds like you might be feeling alone. It sounds like you might be feeling scared. An affirmation for someone who says, are you giving up on me? We'll go through this together. I'm here, and I'm here to talk about this with you. So instead of responding to a question with facts, you want to respond with empathy to the emotion that's behind the question by using these communication skills that we've been talking about. Something like, it must be hard going through this. It can take as little as 40 seconds for an empathetic response to help ease high levels of emotion. Remember, we talked about when people are at high levels of emotion, they may not be able to listen and retain information that you're giving them. But if you can respond with empathy and recognizing the emotion and respond in ways that are helping them to reduce their anxiety and stress, they may be better able to process information again. In less than a minute, you can do this. If a patient really wants facts and an answer to their question, they will likely ask it again. So remember, try to first respond to emotion. It only takes a few seconds, but it can help by building a stronger relationship and rapport with the patient and their family.
Crystal said the very hard question, why me? Yeah, I think this next slide too will help kind of clarify with that too. Is ask, tell, ask. So is there a way to handle questions when a patient continues to ask after a clinician responds with empathy?
Yeah. And we're going to talk a little bit about this. I was thinking about Crystal's question, the very hard question, why me? Thinking about, a great way to respond, it sounds like you might be feeling scared. It sounds like you might be feeling unsure of what's next. Because the unknown is super scary.
Absolutely.
Yeah. So ask, tell, ask, and we may have time to watch this video, but I'm not sure that we have the link totally ready to go. So I don't want to throw a here. But this is a great video that I would suggest that you all take a moment to watch whenever you get these slides, and you could probably copy and paste this. Ask, tell, ask is actually a communication skill that can be used anywhere. It's not just in goals of care conversations. I like it because it helps me. It's really simple and it helps me with questions. It's a communication method that includes asking patients open-ended questions, so kind of exploring questions, you explore, and assessing their existing knowledge before sharing information. So like we talked about before, when you realize, okay, they're asking me questions, I think they want some facts now. We've responded to the emotion, now they want some facts. The central message of it is a shift away from telling patients what to do to asking them to work collaboratively in what they're willing to do. And I'll get to this. So the first ask is asking a patient to describe their current understanding of their medical illness and care. Saying something like, I want to make sure we're on the same page. Can you tell me what your understanding is of your illness and why you're here? The other thing you could ask is, what have other clinicians and staff told you about your illness since the last time we spoke? So then getting a response, obviously, from the patient or the family about, their condition. And then you can say, okay, what I heard you say is you know ABC about your cancer. Here's what I want to share with you. You are, that is what's going on. And the treatment options that you've been offered are this, this, and this. And here are some of the side effects or the adverse effects that you might experience with these. So give them 2 to 3 pieces of information at a time. And you want to avoid medical jargon, because remember, emotion can still be a little high here. When you're giving small amounts of information, it's more helpful. So say someone wants to talk about, CPR. Tell me what your understanding is about CPR. They tell you, well, I see it on ER and it works really well. And they restart people's hearts. And you say, well, I hear what you're saying, that you've seen this on television. I'd like to talk to you a little bit more about what occurs in the hospital setting when someone receives CPR. 1, the heart has stopped. And 2, it's a very involved procedure, and people are often intubated and remain intubated afterwards on a artificial breathing. So the healthcare clinicians are making sure oxygen is getting to, or air is getting to the lungs and then out through the body. So you see how you kind of really take it down to the most basic. And then the last ask is that you ask the patient or the family if they understood what you just told them. So again, you just ask them to state in their own words, tell me what you just heard me say. Or, again, it's an ask. It's, can you relate back to me? Or can you state back to me what I just told you? This way you can check their understanding. Did they get the information straight that you gave them? Did they hear what was said?
That's very helpful. I think sometimes just that keeping the conversation going like that and really getting them to think and reflect back to you has got to be really helpful. So REMAP, Dr. Carpenter, what does this acronym mean? REMAP.
REMAP is another communication method that we call it a 5-step talking map for goals of care conversations. And again, you can find these resources on the VA website. They have printouts of these. It's an approach for structuring the goals of care conversation, and can be really helpful when a patient may not be reaching their goals to regain a functional status that they had previously thought they would, or they may be encountering complications which make their previous goals unrealistic. It's a really good tool for transitioning goals of care when a person's changing throughout their illness trajectory, and there are time points where you need to have a discussion about these changes and about the treatment decisions. And so the first part, again, you see that's the REMAP stands for reframing, expecting emotion. We've talked about that a lot today. Mapping, aligning preferences, and planning treatments. So during reframing, you state how things may be different than they were 1 week, 2 months, or 1 year ago. And again, you want to use these approaches after you have tended to emotion, after you've built rapport, when a patient is ready to continue on with the goals of care conversations. So you say, okay, well, how were things? I often ask patients, and especially those in long-term care facilities, tell me how dad was a year ago. Tell me how dad was 6 months ago. And oftentimes a family member, if they're making decisions if they're the surrogate decision maker, by stating how they see things change, they start to come to their own understanding of the decline that their family member has experienced. Again, expect emotion. So whenever a patient or their family is talking through how things have changed, expect emotion, anger and sadness, and respond with some of those techniques we talked about today. Things, affirmations, simple reflections, complex reflections, exploring. And then you can move on to mapping and talking about what's important to the patient. What are they most worried about? exploring questions are really important. And then once you receive those answers about what's important and what they're most worried about, thinking about the preferences, and kind of what their preferences are, what's important to you. Well, being with my grandkids is really important to me. Okay, well, I heard you say being with your grandchildren is really important to you. How do you feel when you're coming to the hospital and you're spending more time in the hospital than you are at home with your grandkids? It's a way to kind of start aligning their preferences. And then planning treatment is making recommendations that align the goals of care that were discussed in mapping, that you clarified when you were aligning preferences to plan a treatment. Since you said that you really want to be spending time at home with your grandkids, and the past 3 months you've spent, 6 weeks in the hospital, how can we plan your treatment so that you could be home more and we can bring more care to you at home where you want to be? So that's kind of a simple way. Nothing's ever that simple, but it's just a simple example of how to use remap.
Mhm. Thank you.
So this next slide, which I really, would encourage you again to visit this website, is a kind of cool interactive experience, I guess I should say, with a kind of a standardized patient that's actually like I forget what they call them, avatar. And like an avatar, and then you have the opportunity to guide the goals of care conversations and use some of the skills we talked about today. I think it takes about like 15-20 minutes to do. And again, it's freely available. So it's an actual training that lets you go through a goals of care conversation with a patient. One of them is specifically for social workers, nurses, chaplains on the interdisciplinary team. And then there is a separate one for prescribing providers, so NPs, PAs, and physicians. So you can choose whichever one that you think would be best for your learning.
That's great. That's great. We'll send all these slides out afterwards so everyone can take a look at that and get some practice in. Great. So before we wrap up today, there are 4 poll questions we would like to ask today. We're going to put them up on the screen and take a look and select the answer that is best for each, and then we'll all go through together.
Yeah, so Hope, go ahead and start the poll. Start your answers.
Great.
And answer these based on the best information that you received today.
We have just a little bit more time, then we'll go through together. Okay, let's take a look at the poll results. Here we go. Will you walk us through these, Dr. Carpenter? See how well we did?
Yeah, this is great. Fantastic. So that's one thing that's been fun about Zoom is we've all gotten better at using it, that we can have more interaction and not just a kind of talking head in front of slides here. So yeah, understanding a seriously ill individual's goals of care allows you to align the care that's provided with what is most important. Fantastic. Yeah. And then poll question number 2, the consequences of giving too much information include all of the above, right? Consequences of giving too much information may be that you give information that's not important. When we have emotion as clinicians, we tend to talk. It is so hard to not talk and allow for silence. And it's a big joke when I'm with some of my palliative care colleagues that, we'll be listening, we'll be at a lecture and then the lecture will end and it's like, ask for questions and everyone's silent. And the speaker, you say, well, we can stay silent. I'm really comfortable with silence. I'm a palliative care clinician, right? So it's hard sometimes to allow for that silence because we want to talk, and then we end up giving information that's not important.
Sure.
And you're right, patients may not absorb information, and the families may experience overload. So all of these are correct. And question number 3, we can go to the next slide. And as we're finishing up here, I want to make sure you have time to ask questions. So if you have questions, please put them in the chat now while we're going through these follow-ups. So the central message of Ask, Tell, Ask is, yes, asking patients and families what they understand about the illness. We're not asking staff to work collaboratively. We're not telling patients what they should understand. We're not telling them what they should do. So excellent. And the last question, opportunities for goals of care goals of care discussions include both A and B. Yep. So when a patient talks about wanting to discuss future care and when they experience complex care requirements. So excellent job. I'm so glad to see everyone has really learned a lot today.
Yes, great job, everyone. This has been wonderful. This has been incredible information, Dr. Carpenter. You've been wonderful, and thank you for our audience members. You've been amazing. Thanks for all the interaction with us. A reminder to our attendees today, we're here to support you with all these difficult conversations again. So please utilize us. We're here to help. And Lauren, I will turn things over to you to wrap it up.
Thank you so much. Thank you, Dr. Carpenter and Lauren Blair, for this presentation on a topic that may be relevant for many of us. And thank you to everyone who has joined us today. We hope the information was useful for you. We encourage everyone to attend our next webinar on Tuesday, August 20th at 12 p.m. The topic will be on innovations in cardiac care for hospice patients. Please visit our website soon to register. To wrap things up, we ask that you take a couple of minutes to fill out a short survey. By filling out this survey, you will allow us to provide your continuing education credits to you via email, and your feedback will help us bring relevant programs to you, your practice, and those you care for. To complete the survey, visit the chat box. You will need to click on the appropriate link for your field or scan the QR code on the screen now. You will be able to print your certificate of completion immediately after completing the survey. Additionally, you will receive a follow-up email later today containing the links to the surveys. Please remember that you will need to fill out the survey within 24 hours in order to receive your continuing education credits. This was a presentation from the Coastal Caregiver Academy, supporting and empowering our caregivers in our community. At Coastal Hospice, we are here for you, and you can call us anytime on the number on your screen above. Thank you once again for joining us. I am Lauren King, and have a wonderful rest of your day.